Hello everyone, and welcome to this second episode of Road to Venice 25. Today we will talk about pelvic congestion syndrome. The definition of pelvic congestion syndrome is chronic pain to the lowest part of the pelvis caused by the accumulation of blood in the vein of the pelvis. Pelvic congestion syndrome is often an untreated condition with symptoms such as pelvic pain, perineal heaviness, and postcoital pain. We know that venous hypertension is a leading factor in the development of this syndrome. Professor Mark Whiteley, that is an opinion leader about this topic, who will tell us in simple words what pelvic congestion syndrome is.
So basically, pelvic congestion syndrome can be thought of as varicose veins of the pelvis. And I don't think nowadays anybody would find that very surprising, but I think it's sometimes forgotten when you see some of these papers coming out of certain countries. We tend to start concentrating on the product that's been put into the patient rather than the actual what the patient's got wrong with them. So I'm very simple. I'm a surgeon, and I don't like thinking like physicians, very complex. So I like to think about the basics of every disease. And the basics, as far as I'm concerned, is blood goes from your toes to your heart. And it goes through your leg veins, and then it goes through your body veins. And we all get taught at medical school that if it falls out of your leg veins, is your great saphenous vein and anterior accessory saphenous vein reflux, or your small saphenous vein reflux, depending which vein it goes down. And increasingly, people are starting to understand about perforators, which we've been talking about for ages. But basically, if blood doesn't go back towards your heart in your legs, it's varicose veins. But for some reason, as soon as you have the same problem in the pelvis and abdomen, people suddenly start going, oh my gosh, that's different. And it's not. The only difference is emotional, that it's inside the body. But all the things we've learned about veins in the last 20 years, suddenly we start changing our mind as soon as it's in the body, when it's just the same problem. What we proved right back in, I think it was 2009, we actually looked at two different units, a specialist unit on veins, which is our own unit, and the local NHS hospital. And we found 1 in 6 women who came with leg varicose veins have got a major contribution from the pelvis. So that means if you're treating varicose veins, every 6 patients you see, ladies, 1 of them should be having the option, maybe not having, but having the option of pelvic vein embolization, or else they would just keep getting their veins back again and again and again. So this is part of the same system as leg varicose veins. It's not a different condition, it's the same condition.
So the estimated impact of pelvic congestion syndrome is 1 on 6 patients that refer to us with varicose veins. So in case of atypical varicose veins of the lower limb, or in the presence of some symptoms of pelvic pain or perineal heaviness, we should investigate for pelvic congestion syndrome. But which are the risk factors and what the guidelines recommend us to do? Here you have the answer by Professor Pierluigi Antignani, that was the first author of the last UIP guidelines about this topic.
The risk factors for pelvic congestion syndrome are 2 or more pregnancies or hormonal increase. The older gynecologist told that all women with 2 or 3 pregnancies have all a pelvic reflux in ovarian veins. Is rare in nulliparous and postmenopausal women. Mark present 10% of these patients, and there are also other conditions, gynecological conditions. The condition is due to ovarian reflux with the dilatation of pelvic veins, quindi reduction of flow and stasis, abdominal hypertension, and congestion and atypical varicose vein of the lower limbs. The flow chart for the management of these patients, when we have the chronic pelvic pain, we do the transvaginal Doppler ultrasound, and according to the results, we start with MRI or CT and pelvic phlebography to treat the reflux with embolization of the compression with the.
Well, so now we know what pelvic congestion syndrome is and how to do a correct assessment of the patient. But how to treat pelvic congestion syndrome? Here you have the speech of Professor Marco Fernetti of Las Vegas in Venice that is going to tell us how to do it.
We do a normal femoral access with local anesthesia. We catheterize the left renal vein. The shape of the catheters are made that when you put inside the vena cava, the catheter goes directly inside the renal vein, so it's not hard. We do the phlebogram with or without Valsalva to check the reflux. And after the gonadic left vein catheterization, we do another series of phlebographies to check the battlefield, the field where you have to put in the coils. After that, you have to do a super selective obliteration of each vein, the main vein and the satellites vein. You have to close everything inside the pelvic field. Sometimes it happens that you have to do the same thing in internal and external iliac veins. Sometimes it happens then when you catheterize the left gonadic vein with your catheter, you reach the right gonadic vein because the connection inside and outside the uterus are binding those two systems. With these findings, you can evaluate not only the results, but even the recurrence of the pathology. The good one is that if you have recurrence of pathology, you can embolize twice or 3 times.
Anyway, sometimes be too aggressive in the treatment of pelvic congestion syndrome could be not necessary. Please carefully take care about the advice that Professor Ruben Carvajal gave us.
I want to make a few comments regarding this pathology because we have a little experience treating pelvic venous disorders for more than 400 cases. And the first thing is talking about primary gonadal insufficiency and the embolization process. Because we start to be aggressive at the beginning, embolizing distally, embolizing the varicocele and the trunk. But we are realized with experience and with time that in pelvic case, I think that Professor Wiley would agree with this, is more a descending problem, a descending disease that not as happens in legs. And we found that embolization of the trunk usually is more than enough to release the hypertension and to release the symptoms. So that's what we are doing from the last 200 cases. And we found the same results in clinical release in these patients. And even we had some complications for excessive packing of the varicocele with inflammation of tubaric and the ovarian. So we have to remove this coil. So it's just to send this message that take care when you are embolizing distally in women, especially in young women, because after we have pregnancy, we have active sexual activity, and that could be a problem in the midterm and long-term follow-up.
Well, so now we know a little bit more about pelvic congestion syndrome. Don't miss next episode to Road to Venice to hear more about topics regarding venous insufficiency, deep vein problems, aesthetics topic. But most of all, don't miss next vein in Venice. Here you will find in the text the link for the latest guidelines about pelvic congestion syndrome. See you soon.